Good morning or good
Hello,
noon, I should
everybody.
say.
Hello.
We're going to go ahead and get started. Thank you so much for joining us this afternoon for Men's Defense. I know that this is an especially challenging time for our UNC community, and we're glad that you're able to be here with us today. We're all used to virtual presentation formats by now, but before I introduce Min, I just want to lay out some just general guidelines. After my brief introduction, Min will give a 35-minute presentation, and this will be followed by 15 to 20 minutes of questions and answers. Please be on mute during the 35-minute presentation, and during the Q&A, you can unmute yourself if you have a question and then go ahead and ask, or you can ask your question through the chat box. Someone's going to be monitoring the chat box during the whole presentation, so if there's a technical issue, please let us know on chat box, and we will do our best to fix it. So I'm so happy to be here with Min today. I want to start by thanking her committee members, Heidi Hutton, Luz McNaughton-Rice, Kate Messig, and Brian Pence for their amazing support throughout this process. In 2013, Min graduated with a medical degree in the top 3% of her graduating class at Hanoi Medical University, the oldest and most prestigious medical school in Vietnam. After completing her medical degree, Min attended UCLA and received an MS in epidemiology. She was a lecturer at Hanoi Medical University for 2 years before joining us here at UNC. I first met Min while she was at Hanoi Medical University in Vietnam. She approached me in Vietnam to ask if she could write a paper using a data set from our study among men who have sex with men in Hanoi. Many people have approached us to work on our data, and we're always happy to collaborate. At the same time, we often know that good intentions don't translate into action. But Min analyzed the data, collaborated closely with our team on drafting the paper, and the paper was accepted to the International Journal of STD and AIDS within a year and a half, an impressive timeline. At UNC, Min received the prestigious 5-year Royster Fellowship, and during her time here, Min has had many impressive academic accomplishments. She has published 7 first author papers and 6 co-authored papers, and she has several more in the pipeline. She has had 6 abstracts accepted at international conferences, and just yesterday, she gave an oral presentation on her second dissertation paper at the International AIDS Society Symposium on Global Mental Health Care. She's currently a project coordinator on a large implementation science trial that is occurring in 42 ART clinics across 10 provinces in Vietnam, and has been project coordinator on 2 smaller mixed method studies in Vietnam, one on mental health and another on alcohol use in ART clinics. At UNC, she's also been an active member of our community, receiving the UNC Leadership Development Scholarship to organize a global health virtual symposium for students interested in working in global health. Much of what Min does and what she excels in is not quantifiable. She has an amazing ability to thrive in basically any setting. She can easily navigate sensitive topics with the highest levels of the Ministry of Health in Vietnam, and is just as happy to get into the weeds of transcribing qualitative interviews and coding data with her peers. And as if these amazing accomplishments were not enough in their own right, Min did all of this while living far away from her family for 2.5 years. When the pandemic hit, she was in Hanoi, where she managed to continue working closely with her committee members virtually. I would be remiss if I didn't mention Min's non-academic achievements over the past 4 years as well. She gave birth to a beautiful daughter 2.5 years ago and is about to have her 3rd child, both in the US. She ran the New York City Marathon, and mind you, she's not a runner, she just thought it would be a fun experience. And don't laugh, you may not be impressed with this, but she bought and sold 2 used cars on Craigslist. My husband and I were amazed. I don't know about you, but I've always been scared to buy a used car from an owner. She was not some naive purchaser that was going to be conned. She taught me and my husband what to look for in used cars and how to spot a scammer from a mile away. Once again, flexing her diplomatic muscles to negotiate the right price for the right car. And finally, one last little story. Last week, while 8.5 months pregnant and preparing a proposal for her postdoc, and while preparing for this defense, she casually dropped off homemade Vietnamese rolls at her house in her used car, by the way, just because. Minh is incredibly bright, humble, warm, funny, adventurous, and one of the most generous people I know. It's really great to have all of you here. We're so happy that her husband Lynn and her parents are all able to join from Vietnam virtually, even though it is at 11 at night. And I heard, Lynn, that you even got your daughters up to listen. This is just another reflection of the incredible dedication and support that they have given Minh throughout this process. We are also recording this so that her friends and family, including her small children, in case they're too sleepy now, can listen, and they may not have been able to stay up to watch. And with this, I'm going to turn this over to Minh.
Thank you so much, Vivian, for your introduction. And thank you everyone for coming here today to listen to my dissertation defense. Yes, so I will get started with my presentation. You can see it, everything. Okay. Hi everyone, and thank you so much for being here today, and welcome to my dissertation defense. So Dr. Vivian Go is my committee's chair, and Dr. McNaughton Brace, Dr. Muesik, Dr. Pence, and Dr. Hutton are other members of my committee. Today I will be presenting my dissertation research titled Drinking, Mental Health and HIV Outcomes Among People with HIV and Hazardous Alcohol Use in Vietnam. This is the outline of my presentation. I will start with the background and some research gaps, introductions to the parent study, as well as the theoretical framework of my research. And then I will present the conceptual model and aims, as well as the findings of each aim. And I will end with an implication sections before opening the floor to questions. As you might already know, we're in the middle of a mental health crisis, both on our campus and across the globe. COVID-19 has really taken a toll on the mental health of everybody. And in the efforts to raise the awareness of mental health and combat mental health problems, we just celebrated the World Mental Health Day on October 10 and had a wellness day across our UNC campus just yesterday. Through our own experience or through what we've seen happening with people around us, we all know how important mental health issues can be and can seriously impact a person. And I chose mental health as one of the main topic of my dissertation because I think mental health has always been an important issue, but also one of the most neglected topics in public health. So as you can see here, this map shows the latest data on mental health disorders as a share of total burden disease globally. So disease burden here is measured in daily or disability adjusted life years, both from years of life loss and years lived from a disability. And the share ranged from less than 2% to 14%, depending on the countries and the region. Among people with HIV, depression and anxiety are the two most common mental health disorders. It is estimated that people with HIV had from 1.6 to 4 times higher the odds of having depression and anxiety compared to those without HIV. And there are many consequences of depression and anxiety among people with HIV, including reduced economic productivity, damaged social relationship, poor adherence, and faster progression to AIDS. Alcohol use disorder is another comorbidity affecting a lot of people with HIV. So between a quarter to almost half of people with HIV have hazardous alcohol use, which is defined as a quantity or pattern of alcohol use that can increase adverse health outcomes. High level of alcohol use are linked to increased risky sexual behavior, damaged liver, reduced adherence, and increased risk of treatment failure. So the problem is depression, anxiety, and hazardous alcohol use often coexist because they're very much closely linked to each other. Studies have shown that about 10% of people with HIV have both depression symptoms and hazardous alcohol use. And with almost 38 million people with HIV globally, the combined comorbidity of hazardous drinking and common mental health disorders is likely to affect millions of people. So what are the research gaps? First, there is little research on the impacts of mental health symptoms on HIV outcomes among the subgroup of people with HIV who also has hazardous alcohol use. Second, studies on the interaction between alcohol use and mental health symptoms remain scarce. And finally, it is not clear whether alcohol reduction interventions have an impact on mental health symptoms of people with HIV. My dissertation research is a secondary data analysis of a parent study called REDART, or Reducing Hazardous Alcohol Use in HIV Viral Load, a randomized control trial in antiretroviral treatment clinics in Vietnam. So Vietnam is a country located in Southeast Asia, and the star on the map in red here, it's where the Thanh Nguyen province is located. It's a mountainous, multi-ethnic province located in the northeast of Vietnam, and this is the map of Thanh Nguyen, and the HIV epidemic in Thanh Nguyen has been primarily driven by injection drug use. So why did we choose Vietnam and Thanh Nguyen as the study location? Alcohol use and alcohol-related problems are very common in Vietnam, especially among men, with about 40% of men classified as having hazardous alcohol use. And alcohol home brewing is a popular practice, with some people making hundreds of millions of liters of alcohol annually, because many Vietnamese people believe that this type of alcohol is very good for your health. And the widespread availability and affordability of alcohol makes it very easy for people to buy alcohol, and the social pressure to drink and the connection of drinking with social support create additional challenges for people to quit drinking. However, a mental health problem is also another big problem in Vietnam. And you can see in this graph here that the share of total disease burden of mental health disorders have increased from 3.7% to 5.6% from 1990 to 2016. And there was a serious shortage of mental health workforce in Vietnam. As you can see in the graph, the number of psychologists per 100,000 Vietnamese is 0.09. And the number of psychiatrists per 100,000 Vietnamese is 0.91. And just to compare, this number is 12.4 in the US, which is more than 13 times higher. So back to the parent study, REDART, I will now present a characteristic of the parent study. In the parent study, 441 HIV patients in 7 ART clinics in Thanh Nguyen were randomized to receive a brief intervention, a combined intervention, or a standard of care arm, and they will follow up at 3 months, 6 months, and 12 months after the intervention. Participants randomized to the standard of care arm received only standard of care services such as harm reduction services, ART treatment, referrals to substance use, and other sexually transmitted infections. Whereas those in the combined intervention had a total of 6 face-to-face counseling sessions and 3 optional group sessions. And the brief intervention condensed them into an even shorter format, with 2 individual face-to-face counseling sessions and 2 individual phone sessions. So both interventions combine aspects of cognitive behavioral therapy and motivational enhancement therapy, with the brief intervention being a shorter version. So I will talk a little bit more about the therapy that underlie this intervention. So cognitive behavior therapy emphasized the role of cognitive processes in treating emotional disorder, and it assumed a close link between feelings, thoughts, and behavior, and it aims to change behaviors through social learning and skill building. Motivational enhancement therapy, on the other hand, it's a client-centered counseling style, and it was based on motivational interviewing, and it added personalized feedback about alcohol use to the client in order to increase their motivation, readiness to change, and commitment to change. 4 processes of motivational interviewing included engage, focus, evoke, and plan. So here are the inclusion criteria of the study. Participants were enrolled if they were current client on ART at the clinic, classified as hazardous alcohol, having hazardous alcohol use based on the ODIT-C scale, 18 years of age or older, and stay in Tangwin for the next 24 months since the start of enrollment. And participants were excluded from the study if they were unable to provide informed consent due to various reasons, unwilling to provide contact information, or currently participating in other HIV or alcohol studies. Here's how some key variables were measured. Apart from basic social demographics characteristic, we also measure 2 mental health symptoms, namely depression symptoms with the Patient Health Questionnaire 9 and anxiety symptoms with the Generalized Anxiety Disorders 7. HIV outcomes include viral suppression, which is defined as having less than 20 copies HIV RNA per ml of blood, and complete ART adherence, defined as not missing any pills in the last 3 months. And alcohol use was measured as a continuous variable with percentage of days abstinent from alcohol out of the last 30 days. And we also measure alcohol dependence, which is a binary variable based on the mini international neuropsychiatric interview. Moving on to the theoretical frameworks of my study. So the first theory informing this research is the transactional model of stress and coping. So according to this theory, experience of stress through primary and secondary appraisal or assessment of the stress and coping effort can have a negative influence on emotional well-being, functional status, as well as maladaptive behaviors such as hazardous alcohol use and non-adherence, which in turn will also affect the health of participants. Another theory underlying my study, it's the syndemic theory. So syndemic means a dynamic relationship between 2 or more diseases that can interact with each other. In other words, the coexistent and synergistic interaction of more than one condition can produce worse health outcomes compared when they exist separately. So in this graph, you can see, for example, factor A, it's mental health disorder, and factor B is alcohol use. They are very much closely linked to each other. They both affect HIV health outcomes, and they can interact with each other to worsen the impact of one another on HIV health outcomes. And there are also some theories underlying the 2 therapies used in intervention. So for CBT, it's the cognitive theory, and for MET, it's the cognitive dissonance theory and self-perception theory. Now we'll just put everything together to show you the conceptual model of my study. So you can see here with people with HIV, there might be individual factors and environmental factors that can affect their alcohol use and their mental health, which in turn can negatively affect their health behavior, such as ART adherence, and the physical health, such as viral suppression. And the 2 interventions using CBT and MET can change readiness to change and coping skills of participants which in turn can change the alcohol use and potentially also mental health symptoms. So here is the summaries of my aim. Aim 1 will look at how the mental health symptoms affect HIV outcomes. And the sub-aim 1 will look at how alcohol use modifies this association. My aim 2 will look at how the interventions impact mental health symptoms. And the aim 3 look at the role of alcohol use as a mediator in the pathway from the intervention to the mental health symptoms. And this is how each theory maps onto each aim. So for aim 1, it's the transactional model of stress and coping. For sub-aim 1, it's the syndemic theories. And for aim 2 and aim 3 is the theories underlying cognitive behavioral therapy and motivational enhancement therapy. Now I will present the methods and findings of each aim in detail. So aim 1, just repeating information from the previous slide, aim 1 will evaluate the longitudinal association between mental health symptoms, namely depression and anxiety symptoms, and 2 HIV outcomes, viral suppression and complete ART adherence among ART clients with hazardous alcohol use in Vietnam. And the sub-aim 1 will determine whether alcohol dependence modifies this association or not. In aim 1, we use generalized estimation equations or GEE models to analyze longitudinal data. And because the outcomes of complete ART adherence and viral suppression were quite common, we used Poisson regression with robust variant estimation. And we estimated the risk ratio of viral suppression and adherence associated with a 5-unit change in mental health symptoms. And we also added interaction terms between mental health symptoms and alcohol dependence to evaluate effect modifier. And finally, multiple imputation was used to deal with missing data. First, I want to present some baseline characteristic of the sample. So the mean age of the sample was 40.2 years old. The majority was male, married, employed, and had at least some secondary school education. Alcohol dependence was identified among 21.1% of participants. And we saw that depression and anxiety symptoms was pretty common at baseline, with 25.5% having depression symptoms and 16.1% had anxiety symptoms, and 13% had both. So just to clarify, for both scale, PHQ-9 and GAT-7, a cutoff score of 5 was interpreted as having a mild level of symptom consistent with depression and anxiety. And at baseline, we saw that 84.1 were virally suppressed and 76.4% had complete ART adherence. As you can see here, on the right, the estimates in red, both depression and anxiety symptoms were associated with a lower likelihood of complete ART adherence. However, we did not see any association between mental health symptoms and viral suppression. And when we look at alcohol dependence as the effect modifier, we saw that it was a significant moderator, such that between the association between anxiety symptoms and complete ART adherence, such that the association was stronger among participants with alcohol dependence compared to those without. So at 3 months, you can see that the association were both significant in 2 groups, but it was stronger among those with alcohol dependence. And at 6 months, it became significant only among those with alcohol dependence. So to conclude, in aim 1, we found that depression and anxiety symptoms were common as baseline. and they were associated with the lower probability of complete ART adherence, although they had no overall effect on viral suppression. And alcohol dependence was a significant effect modifier, such that the negative effects of anxiety symptoms on adherence were stronger among those with alcohol dependence. Moving on to AIM-2. So AIM-2 will describe the changes in depression and anxiety symptoms over time and assess the impact of 2 interventions on depression and anxiety symptoms. Similar to AIM-1, we use generalized estimating equation, or GEE, to estimate the impact of the intervention on mental health symptoms. And we also report the changes from baseline in the symptoms by intervention group, and as well as the differences between intervention group at each follow-up visit. And interaction terms between the interventions and time were included, and we also use multiple imputation to deal with missing data. So as you can see in this graph, this is the change in depression symptoms and anxiety symptoms over time. The line in orange is the brief intervention. The line in blue is combined intervention, and in gray is the standard of care. So decreases in anxiety symptoms and depression symptoms were observed in all 3 arms over time. However, when we use multivariable models controlling for baseline symptoms, we didn't see any significant differences in depression and anxiety symptoms among the arms over time, except that at 6 months, depressive symptoms score was significantly lower among the brief intervention compared to the combined intervention. So to conclude the second aim, decreases in depression and anxiety symptoms were observed in all 3 arms over time. However, there were no significant differences in the symptoms among participants receiving either intervention relative to the standard of care arm. Now moving on to my last aim. AIM-3 will examine the mediating role of alcohol use in the pathway from the 2 interventions to mental health symptoms. A participant at the last follow-up visit. In other words, we'll see whether the change in alcohol use created by the intervention will lead to any changes in mental health symptoms. So for AIM-3, longitudinal structural equation models, or SEM, was used with full information maximum likelihood. Because this technique allow for the assessment of different pathway from the exposure to the mediator to the outcome. And we compare lag B-path versus contemporaneous B-path models. And I will show you how they are different in the next slide. And different fit indices such as the CFI, TLI, RMSEA, BIC, and AIC will also use as is our standard fit indices used in SEM. Here is a comparison of a lag versus a contemporaneous B-path. So the only difference between these 2 models is that in the lag B-path, the mediator from one time point was allowed to predict the outcome at the next time point, whereas for contemporaneous B-path model, the mediator will predict the outcome at the same time point. And the reason for this comparison, it's because even though lag models can better, ensure the temporal order between the mediator and the outcome, sometimes the contemporaneous B-path model might be more appropriate if the time lag is long enough for the effect of the mediator on the outcome to happen at the same time point. So the indirect effect is a sum of all pathways that went through at least one measure of the mediator, which is alcohol use. And the direct effect is a sum of all direct pathways or pathway that did not go through any measure of alcohol use, just straight from the intervention to mental health outcomes. And I will show you example of this pathway in the next slide. And the total effect will be the sum of both indirect and direct effect. And we use bootstrap procedures with the sample size of 5,000 for 95% confidence interval. So here is an example of an indirect versus a direct pathway. So as you can see in this graph, X is intervention, M is the mediator, and Y is the outcome measured at different time point. And an example of an indirect pathway, it's from X to M2 to M3 to Y. So it goes through at least one measure of alcohol use or the mediator. Whereas an example of a direct pathway is from X to Y2 to Y3 because it did not go through any alcohol use measure. So moving on to the result of M3, when we compare the lag versus the contemporaneous model, we see that a lot of the feed indices were similar. However, the difference was in the BIC and the AIC. And because lower BIC and AIC indicated better fit, we chose the contemporaneous models as the final models for our study. So here are the estimate of each path when the impacts of the intervention on depression symptoms were estimated. And you can see that there was a significant impact of the intervention on alcohol use. And then lower alcohol use in turn were associated with fewer depression symptoms. And this association was significant. However, in the model testing the impact of the intervention on anxiety symptom, you can see that the intervention still would have a significant impact on alcohol use. However, there was no association between alcohol use and anxiety symptoms. So finally, this table shows all the indirect and direct and total effects of two interventions on two mental health symptoms. As you can see here, there was a significant indirect effect through alcohol use of the intervention on depression symptoms. In other words, alcohol use was a significant modifier of the significant mediator of the pathway from the interventions to depression symptoms. So to conclude, alcohol use measured as percentage of days abstinent from alcohol in the last 30 days was a significant mediator of the pathways from two alcohol intervention to depression symptoms, but not anxiety symptoms. So what are the implications for future research and policy? In terms of future research, we see that alcohol use has an impact on depression symptoms, but more studies should be done to understand the exact mechanism through which alcohol use impact this mental health outcome. And because people don't exist in a vacuum, we need to identify factors that can modify this association between alcohol use and mental health, especially interpersonal and environmental factors such as alcohol norm, stigma, and social support. And future research should also use other diagnostic tools such as the full mini questionnaire to discriminate between mental health symptoms and the larger diagnosis of a mental health disorder. And finally, research among more representative and larger a group of people with HIV, for example, those that include people not on ART as well, is needed to increase the generalizability of the findings. These findings also highlight the urgent need for interventions targeting depression and anxiety for people with HIV, who also has high levels of alcohol use. So the first important step is to raise awareness about the seriousness of mental health problems among this group, and then to provide mental health services such as screening, counseling, or medication treatment. And because mental health disorders and alcohol use disorders often coexist, we should incorporate mental health components into alcohol reduction intervention. to simultaneously target these comorbidities. In addition, we can use transdiagnostic intervention, which means an intervention that can apply the same underlying treatment for across different mental health disorder might be necessary, given that a lot of patients can have different mental health disorders at the same time. Finally, more implementation studies are needed to see if the scaling up of this intervention would be feasible and sustainable in low and middle income countries. These studies will help us understand the barrier and facilitators of implementation of mental health intervention in real life setting. We can also test implementation strategies that might work best in this environment, such as integrating mental health care into existing HIV primary care, or using task shifting model. And task shifting here is defined as the redistribution of tasks among different healthcare workforce to make more efficient use of the available resources. In this case, mental health care tasks can be moved from highly qualified health workers to health workers with shorter training or fewer qualification. So that is the end of my presentation, and now I want to take a few minutes to thank everyone who has helped me complete my dissertation. So first and foremost, I would like to express my deepest gratitude to my advisor sitting next to me, Dr. Vivian Go. You are really, it feels weird, like talking to the laptop when you're sitting next to me. But you are the best mentor a student can ever ask for, because we always make sure that your students feel heard and they feel confident in their abilities to conquer new challenge. And to me, you're not just an advisor, you're also a teacher, a role model, and a friend. I was so touched by your kindness when I first arrived in Chapel Hill 5 years ago. And I learned so much from you, not only on how to become a researcher, but also how to be a good mentor and a leader, to the point that now I often find myself asking the question, like, what would Vivian do in this situation? Yeah, and I would also like to thank other members of the committee. Thank you, Luz, for your continuous guidance, which was very important in developing the methodology of my research. And thank you, Kate, for your valuable support throughout my studies and helping me strengthen my proposal and dissertation. And thank you, Brian, for always challenging me to think critically and creatively. And finally, thank you, Heidi, for teaching me so many new things about the complex world of mental health. And I really hope I get to see you in person very soon. This dissertation would not be possible to complete my dissertation without the generous funding of the Royster Fellowship, which supported me through 5 years of my degree. And the parent study was also supported by the National Institute of Drug Abuse and the UNC Chapel Hill Center for AIDS Research. I would also like to thank my colleagues at UNC Vietnam office, Dr. Trần Việt Hà, and all the UNC Vietnam staff for your important contributions to the implementation of REDART, the parent study. And I would also like to thank the larger REDART research team for their support and guidance for my research. And I want to thank Dr. Lê Minh Giang, who provided me with continuous support during my studies here and the Department of Epidemiology at Hanoi Medical University, where I used to work before I come to UNC. And I would like to say thank you to my PhD cohort who struggled with me through the highs and lows of the program. And I'm very grateful to also be a part of the wonderful group of advisee who are Vivian's advisee, including Chris, Chrissy, Adams, Jane, and David. And I always look forward to our advisee meetings so that I can see you and hear your interesting research. And I'm deeply grateful to my parents for helping me get to where I am today. They really set great examples of hard work and set me off on the road of becoming an academic. I would also like to thank my parents-in-law for your continuous love and encouragement and support from Vietnam. and to my sisters who are always there for me, to Linda and Barry, who has helped me tremendously since I came to Chapel Hill, and you are really family to me here, and to Tira for being a special friend who is always willing to help me whenever I need. And last but most importantly, I would like to thank my husband for your constant source of love and encouragement. Your willingness to stay in Vietnam and take care of our kids while I'm in the US, it's something that I'm forever grateful for. And to our kids, I'm so lucky to have you in my life, and you really made my journey so much more special and memorable. Thank you all very much for your attention, and now I will open the floor for questions.
So please feel free to ask questions just directly through, you can just speak up, or if you want, you can use the chat box to ask questions.
Hi, Minh. I have a question. I just wanted to say, first of all, this.
Chrissy, I think you're muted.
I shouldn't be. Can you hear me? Okay. I wanted to say this was an amazing presentation, Minh. You did a fabulous job. I had a question about some of the results you were showing for your first aim. I know you mentioned that you did see an association between anxiety and depression and ART adherence, but not an association between anxiety and depressive symptoms and viral load. And I was wondering if you had thoughts on why that was, since I would have expected if there was an effect on ART adherence, then there would also be an effect on viral load.
Thank you so much, Chrissy, for your question. So yeah, I know like it may be a little counterintuitive to see an association between anxiety and depression and adherence, but not with viral suppression. That's also the reason why we included both outcomes, because adherence and viral suppression might not always be consistent with each other. So for example, a patient can have a high level of adherence, but because of resistance, they might not achieve viral suppression. So and with viral suppression, it might take a longer time for adherence to create an effect on viral suppression. So so we included both health outcomes and compare them with each other.
That makes a lot of sense. Thank you.
Minh, I have a question. Hi. Thanks for sharing your work with us, Minh. That was a great presentation. Maybe a little bit similar to Chrissy. I was interested in the anxiety and depression results. And if I'm understanding the results correctly, it sounded like both anxiety and depression decreased across both of the intervention arms, but it sounded like there wasn't significant findings across those decreases. And I was wondering about your thoughts on the factors that might have played into that.
Thank you, Chris. That's a great question. We in our second study, we did not see any significant effects of the interventions on mental health outcomes, and we see decreases in all three arms, including the standard of care. And this can be explained by several things. First, there's something called the Hawthorne effect. where a participant, just by being enrolled in a study, being followed up and being interviewed, might be more aware of their mental health problems or their behaviors and make changes, even though they're not really, like they're not randomized into the intervention. So that might explain why those in the standard of care arm also see, we see improvement in mental health symptoms. And moreover, because the main focus of these interventions are alcohol use and not mental health disorders. So that also might be that the intervention might have a small effect on mental health symptoms, but we did not have like enough power, or the magnitude of the impact was not large enough to be seen and to move the needle. Yeah, thank you for your question. I hope that makes sense.
It looks like there are, there's a question from Melissa. Melissa Gilkey, I'm curious about how the intervention compared in terms of implementation outcomes. Were there differences in how the interventions were adopted and accepted?
Yeah, thank you, Melissa, for your question. So yes, so I understand that your questions, it's about implementation outcomes of the intervention. But I think REDART is a trial that focused on effectiveness outcomes only. So we only measured the alcohol use over time, as well as HIV outcomes, including adherence and viral suppression among participants. But since this was not an implementation trial, we did not really measure any implementation outcomes such as adoption or acceptability. And I think because the REDART study was proved to be effective, but only in a rigorous research setting, the next step would be to try to scale it up and make it an implementation trial. But that is definitely a great direction to go after the completion of REDART.
And then we have another question from Jane, who congratulates you on your amazing talk and asked about the result that you were most surprised by in your research.
Thank you, Jane, for your question, and thank you for your encouragement. I think the thing that most surprised me in the findings of my research is how depression and anxiety might be very different. Yeah, so usually we see people doing research on depression and anxiety and kind of like, they always like showed up at the same research, but they can mean very different things. And depression and anxiety disorders are two very different mental health disorders, as you can see in this research. So for example, in my AIM-3, I saw that alcohol use had an effect on depression symptoms, but not on anxiety symptoms. And when I look at the literature, it seemed like the association between alcohol use and anxiety symptoms were a lot more conflicting compared to that between depression and alcohol use, because sometimes alcohol use can help to reduce anxiety, but other time and high levels of alcohol use can actually increase anxiety. So I think it's very interesting how two very common mental health disorders that usually coexist actually have very different characteristics and different findings.
I have a question. Great presentation, and thank you for sharing your work with us. Just curious to know if your measurement tools were translated in Vietnamese, and if so, do you believe that had any impact on the results?
Thank you so much, Rose, for your question. And yes, because the study and the questionnaire and everything were conducted in Vietnamese, the scales were also translated, and I administered the scale in Vietnamese. And both the PHQ-9 and the GAT-7 were validated in Vietnamese settings in the past, especially PHQ-9. It was actually used in different various population of people with HIV in Vietnam. Yeah, so we had a lot of research that backed up the validity of using the Vietnamese version among Vietnamese population.
Thank you.
Hi, Minh. I have a quick congratulations first, great presentation. And so I have a question about, like, in terms of this is a longitudinal or long-term intervention study. Have you included any, I mean, not for you specifically, but the research team included any like qualitative progress evaluation for the participants? And if you have any like published work or like work in the pipeline to share from that perspective? Thank you.
Yeah, thank you, Chunyan, for such a great question. And this is also something that I would love to have more time to talk to, but this is definitely outside the scope of my dissertation. In the REDART study, we did conducted a small qualitative among participants to understand how the interventions change their not only alcohol use, but readiness to change, their coping skills, just to understand the pathway and how it affects their social support, and as well as alcohol abstinence stigma. So in Vietnam, there's a very strong norms around alcohol use, where alcohol use is actually encouraged during in social settings, and people might be even forced to drink. And that's why there are alcohol abstinence stigma, where people will get stigmatized if they don't drink during the social events. So yeah, the qualitative research that we are analyzing and we're trying to publish a paper on shows very fascinating findings on how the outside factors, such as the norms of alcohol use and the social pressure to drink, affect a participant even in the impact of intervention. So participants reported that they have improved coping skills and improved readiness to change, but because the social influence is so strong that sometimes it will be very hard for them to refuse a drink or quit drinking. Yeah.
Thank you for that. And I just wanted to mention we have very similar social pressure or social influence in China as well. So I can totally understand that.
Yeah, that's interesting.
Okay, well, thanks to everybody for a great questions and a great discussion. This wraps up the public portion of Minh's dissertation defense. Thanks to all of you for coming and for supporting Minh and for hearing her research findings.
Yeah, thank you everyone for coming and for your very interesting questions.
Congratulations, man. Great job.
Chúc mừng Minh nha.
Congratulations. Very excellent presentation. Yeah.